Would a patient who was hyperkalemic or have high potassium, do you think that affects their cardiac cycle?
Yeah.
What about low potassium? What about high sodium? Low sodium, probably more low sodium than high. What about calcium, low calcium? So understanding how critical in the relationship of those are, if you've got metabolic imbalances where their potassium and their calcium and sodium is off, that can affect their cardiac cycle. And there are EKG changes that you can see that make you go, this may be electrolyte problem, okay? And some of which predispose them to sudden cardiac death as well. All right, so just, just take a look at that 18, and as you get into your medical emergencies, you'll be coming back to some of this stuff. As we talk about overdoses and toxic and stuff like that, you'll come back to some of these things. All right. The other thing to know is that a pissed off heart, because of ischemia or lack of oxygen, is going to throw disturbances into this as well, okay? All right, let's talk about cardiac monitoring, then we'll take a break. So when do we want to monitor the cardiac rhythm? Yeah. When would you want to?
Anytime they complain of chest pains or respiratory distress.
Yeah.
Say complaints from here to here.
Yeah, very good, Reggie. So it is what? It's a tool in our toolbox, isn't it? Along with our assessment and ability to gather, good findings with them, physical exam, medical history, vitals, and all that stuff, a cardiac monitor is something that we can monitor what their rate is, okay? What's their heart rate? Am I seeing any ectopy or any early beats, things like that. So cardiac monitor is that, you're monitoring during transport. You want to, if you can, you want to print off a strip for your interpretation. I will tell you that once you guys get down with static dysrhythmia interpretation, in other words, you're looking at the strips, then we're going to mix it with the rhythm simulator to let you look at it in a dynamic way and be able to start interpreting from a dynamic standpoint and applying those rules, okay? And certainly you can print an EKG for diagnosis, okay? Now, I want to point out there's a key difference between monitoring with an EKG and acquiring a 12 lead. Anybody know the difference between the two? Use the same monitor. So every once in a while I would hear, especially when I took radio reports, and sometimes I hear them even today when I listen to the med channels, I'll hear a paramedic say, yeah, lead 2 shows a normal sinus rhythm with ST elevation. Okay? All that you've told the person on the other end is that they're in a normal sinus rhythm and that maybe you really don't know what you're talking about. Okay? And what I mean by that is there's a difference between lead 2, monitoring lead 2 shows normal sinus rhythm, ST segment elevation, versus I have a 12 lead that shows ST elevation and lead 2, 3, and ABF. That tells them something. That tells them they need to get a code STEMI going. That tells them something. Okay? Because monitor mode, when we're driving down the road, is a completely different thing than what happens when we acquire a 12 lead. So, I need glasses when I read. Okay? So I'm reading, I'm trying to read something, and I can get pretty close on it, can't I? As far as without my glasses, I can squint and maybe hold it out a little bit. I can make out the words, but it's not crisp and clean, is it? All right? I need my glasses to make it crisp and clean. When we monitor, we utilize a completely different frequency. All right? And so when we monitor, we have less artifact, but we don't have as clear of a picture as we would if we were moving to 12 lead mode. Okay? So it's just like I'm reading. I can say, yeah, I can read this thing. It's not crystal clear, but I can see it. Okay? Versus if we switch, when we acquire a 12 lead, the machine switches to what's called diagnostic mode. So we're in monitor mode, and then briefly it switches to diagnostic mode. That's putting the glasses on. And it's really refining what it is that we see. The downfall with monitoring diagnostic mode is you're going to get artifact all over the place. Any sudden movement, twitch, whatsoever, it's going to come across as artifact. What do we tell the patient to do when we say, okay, we're going to acquire the 12 lead?
Hold still.
Hold still. Because any movement whatsoever will be dramatic on the EKG. Okay? So when we're and then as soon as the EKG is done after 10 seconds, the machine switches back to monitor mode. Okay? So the only way, and so I bring up that ST segment elevation, because if you tell me you have ST segment elevation in lead 2, chances are when you do a 12 lead, lead 2 is going to look normal. Okay? So kind of be careful with that, all right? You know, just to do that. We'll talk about ST elevation here in just a second. 12 different angles, we know that. The interpretation, we'll talk more about this when we cover 12 leads specifically, but no, there's interpretive software in there that can be wrong, okay? We don't want to necessarily rely on the interpretive software, rather we want to improve our abilities to be able to read the EKG. And then use the interpretation as a guide to go, yeah, I already knew that. Okay? And you will get to that point, I promise you. Electrode placement, predetermined spots, we talked about that. One thing that's worth mentioning here is that, and depending on the service that you work for and the volume of calls that you do, a lot of people like to pre-connect the electrodes to the wires. Unless you're running a couple of 12 leads, like boom, 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 all the time, the minute you take them out of their package, that median begins to dry out. Okay? That's not a big deal if I'm going to clear it, I'm going to end up using it on the next patient. Or whether it's, you know, like in Kansas City, you guys run a lot. But out here, some of the other services, just keep them in the packages where they're nice and temperature controlled and they stay moist and all that. Just don't preload these things because it does impact. As that salty gel begins to dry out, you get more artifact. And then you're going, damn it, they bought these cheap ass electrodes. You know, no, it's because you preloaded it.
Quick question, what about the brown? Why is that?
The brown wire? So the brown wire is used for what's called bedside monitoring. So if I'm in the ICU or on a telemetry floor, they'll have all these on, then there'll be a brown wire. And then depending on where it is that they're wanting to watch, they'll put that brown wire. And that will be a continued look of like so it will always be looking at one of these leads. Okay? So for example, if I'm managing a patient who's had a heart attack and I've taken them to the cath lab, and I know that they had inferior wall MI, okay? And I knew that it was the right coronary artery was the problem, okay? I know that what I want to do is I want to monitor in a different lead versus another one. So I'll place a specific lead somewhere else. That way if I see any changes, I know, hey, there's a problem going on. So it's really, the brown wire can be anywhere. A lot of times they'll put the brown wire in V1. It'll sit right here in that V1 spot. And it's just depending on what it is that they, you know, you may ask them, why do you put it there? And they go, well, I don't know, it's because I'm trained, but they should say, well, that depends on what we're looking for. Okay? Bedside monitoring is a weakness in the hospital, believe it or not.
So that's not used in pre-hospital?
No. All right, some basic principles of electrode placement come down to three things. If they have hair, you must shave it. If they have oil and dirt, you must clean it off. And then you must abrade the top portion of the skin with like a 4x4 or something. If that electrode cannot adhere to the skin really well, you're going to have artifact. 99.9% of all your artifact that you get in 12 leads, and I see a lot of them, is because we don't prep the skin. All right? So if they have hair, now it may go over some hair, but if you've got a Grizzly Adams or something, you know, a big gorilla, you know, you're going to need to shave some hair in order to place the electrode. All right? Women, they get out of the shower, what do they want to do? Put lotion, man, they put lotion all over the place, right? Well, that electrode isn't going to stick to the lotion. So you need to take an alcohol wipe, clean off where that's going to be in order to get that electrode to stick. Older women, they put electrodes on, but what about their skin?
Swap.
Yes, exactly. You put the electrode on, falls off, and you're bitching about the electrode again. Well, what it is, it pulled that top layer of dead skin cells off. Okay? Take the 4x4, abrade it where you're going to put your electrodes. Okay? Then that gives that electrode some place to stick. I always say do it right the first time and get a good clear tracing. Okay? Because it will be dependent upon on that. Okay, so is everybody clear about the electrical impulse and where it corresponds to the cardiac cycle, where it corresponds to, you know, the P wave is our SA node moving down the atrial kick, the ventricles fire off, that area where I'm in, you know, absolute refractory, and then I go into repolarization and I'm on to the next cycle, okay? Now, you're going to have to do some measuring here, all right? And so what we're measuring for on grid paper is time, all right? And so these are called intervals. So there are normal intervals that we're going to be looking for. So the first interval that we're going to be looking for is what's called the PR interval, okay? So the PR interval starts at the P wave. So whether it's a PR interval or a QRS interval or a QT interval, that first letter tells you where you're going to start the measurement from, the beginning of that. So if I'm going to measure my PR interval, it starts to the beginning of the P wave and goes to the beginning of the R wave, or the Q wave, whichever one I have. Okay? And then that's where my time is. So all I'm going to do is I'm going to count the little boxes, which we haven't covered yet. We will here in just a couple of slides. And that's going to give me my timing, my interval. Okay? If I want a QRS time, then it's going to be from the Q beginning to the S ending. If I had one that comes down, which I don't, the R wave just stops. So I want to know the little boxes between the beginning of the Q wave and the ending of the R. Okay? That's how we get that one. And then the last one is the QT interval, the Q wave to the end of the T wave. Counting those. Okay? Those are going to give me my intervals in time. So, let me draw something here real quick, just so you're aware. Okay? So, a QRS looks like this. This is my Q, this is my R, this is my S, and it comes back to baseline. Does everybody see that? That's how we get QRS. So if I'm wanting to measure my QRS duration, I'm going to start at the beginning of the Q, and I'm going to stop at the end of the S. And I want to count the little boxes in between. I may have this. Okay? Do I have a Q here? Is there a Q in this one?
No.
No, it doesn't drop down. So I have an R wave, and then I have an S wave. If I want to measure my QRS, it starts right here at the beginning of the R and at the end of the S. See that? And I'll leave these up here for you. And I may just have this, which I don't have a Q or an S. So in essence, I'm measuring from here to here. Okay?
Is that still considered the QRS?
Uh-huh. Yep.
Okay.
Yep.
All right.
QRS represents ventricular depolarization.
Right.
Period. And while I'm at it, I can have a QR but no S. Okay? Everybody see that? A Q, R, but no S. So it'd be at the beginning of the Q to the end of that R wave. You count the boxes. All right, so let's look here and see So we know about we know about the leads, where white and right and black and all that go. I can skip over, we covered Einthoven's triangle, the augmented leads, we covered that. We will cover 15 leads and 18 lead EKGs, things like that. We'll just talk about them, when you would use those. We'll talk mainly about that in the 12 lead portion of this. But just know that right here with this configuration, we only have 12. Okay. Now there may be chances, times when I need to check other areas of the heart, which I may put a couple of more electrodes on the chest to acquire. But let's cover that when we get there. Okay. All right. All right, unipolar, we got that. All right, so graph paper. When this thing prints out, it's going to be on graph paper, just like this. In between each calibration, okay, this is on a 12 lead, so I'm not going to worry about that, but you can use a 3 seconds, hold off on that, okay? So in the grid paper, you've got big boxes and little boxes. Okay? So here is a big box that's magnified. And inside the big box, how many little boxes do I have? I have 5 little boxes that make up one big box. Does everybody see that? One big box is on the graph paper, and inside is 5 big boxes. Okay? Each one of these little boxes represents 0.04 seconds. 0.04 seconds. So if I have 5 little boxes, what would one big box be if I were measuring? 0.20. 0.04 times 5 equals 0.20. Okay? So what I want to do when I'm measuring is I want to measure and know what's the timing, how many seconds is it. So say, for example, I wish I could write on this thing, I can't, but let's just say I'm going to measure my R wave. And my R wave starts here, goes up, and comes down right here. Okay, so it starts here and ends here. How wide is that R wave?
0.08.
0.08 seconds. Okay, very good. So let's say that this is my PR interval. Okay? So my P wave starts here, goes up, and my R wave starts right here. What's my PR interval? 0.20. The beginning of the P wave, which started right here, to the beginning of the R wave, which started right here, 1, 2, 3, 4, 5. 5 little boxes equals one big box. So this should be a review here to you. The Q wave's the first negative deflection, the R wave's the first upward deflection, and an S wave is a downward direction after the R wave. Make sense? Should be review. All right. The next thing we'll talk about, let's see where we're going with this thing here. I'll tell you what, good time to take a break. Okay, let's stand up, move around. Some of you got heavy eyes.
Is there any clinical, I guess, if you don't have an S wave or Q, is there any clinical significance? Is there,
No.